right, guys. Thanks to our participants for joining this discussion and for the folks who helped to organize this. This is always a neat opportunity. My name is Dr. Jeremy Gierman. I'm a physical medicine and rehab physician, or a physiatrist as we're also known. And I really appreciate the opportunity to be able to engage in education. In my mind, that's one of the most important parts of what we do as medical providers. So we're going to walk through an interesting topic today. A little bit more about my background. I'm an Ohio guy, so I grew up in Dayton, Ohio, and went to Ohio University for medical school. And then I trained in physical medicine and rehab during my residency at University of Cincinnati Medical Center. And now I practice part-time at the Cincinnati VA, taking care of our veterans, and then part-time in private practice, where I opened a unique clinic in order to practice mostly musculoskeletal medicine. And that's what we're going to be talking about today as it applies to restorative or regenerative medicine. And just to clarify, musculoskeletal medicine is problems with joints, tendons, muscles, ligaments, and we also do nerve care, care of nerve problems. So the topic today is in fact regenerative or restorative medicine for our aging and injured bodies. And this is becoming more and more a topic of discussion with patients. And initially, when I had given similar presentations, the title often was regenerative medicine. And as of recent, I've been transitioning to this word restorative, and we'll talk about the reasons for that. As I flip slides here, one of the most important things for me, like I mentioned, education is paramount. And as part of that education, I like to sit down with patients and discuss terms, number one, and expectations, so that we're all on the same page when it comes to discussing what the patient's problem might be and what potential treatment options might also be. I put a picture of a lizard up here because I think that when a lot of people hear of the word regenerative, as in regenerative medicine, they think of this type of scenario of a lizard regrowing a tail. Or sometimes I've had patients come to the clinic and ask about regenerative medicine for example, a knee. And they get, I think, an idea that, hey, I'm going to regrow my knee to where it was when I was 20 if I'm now 60. And so for me, it's very important to get an idea of where patients are with their understanding of our current treatments and technologies and what the potential options are and the expectations associated with those options. So ultimately, the goal of a lot of these types of therapies that we'll walk through is to encourage tissue healing and to enhance tissue health so that we can improve symptoms and overall function. So even though we might not be able to, for example, regrow a meniscus that was removed during a prior surgery or regrow the cartilage in its entirety that was associated with the previous trauma or injury, our goal remains to improve symptoms, in this case knee pain, by engaging in some of these restorative therapies and enhancing the health of the knee joint. And we'll talk about more of that. So this question of what is restorative medicine, how does it impart its effect, these various treatments, leads us to this kind of foundational question of what's going on here when we're dealing with different problems. For example, knee arthritis. We're all familiar with this problem of arthritis, of course, and it has been described as just a degeneration of knee joint structures, the same can be said for tendon structures, etc. It's sort of a wear and tear phenomenon. But as it turns out, despite the fact that wear and tear, almost like bending a coat hanger one too many times until it snaps, even though that is part of the process, there's much more to the story. So I find it important to walk through that with my patients because it better helps to understand the process and the potential treatment options that we can consider. So in this slide, we're looking at how a joint might progress in terms of going from what looks like a very normal joint to one that has some cartilage lesions, some compromise of the space between the bones in that joint, and just some general degeneration. But let's look a bit deeper. So on this next slide, we're looking at what really occurs within a joint. Now this is a complex slide and I meant for it to be that way, not so that we have to memorize the details, but just to show the fact that as we transition from a healthy to an unhealthy joint environment, and therefore likely a symptomatic joint, one that's associated with pain, there's a lot going on within that joint. So what this picture shows is involved in this process of arthritis or other joint or musculoskeletal problems, there are many different inflammatory cells, many different chemicals, many different enzymes and other things that lead to or further perpetuate the problem. So in the case of arthritis, for example, within an arthritic joint, there are many unhealthy molecules floating around, inflammatory molecules, little enzymes called metalloproteinases. All of these things have long names, but these can be thought of as little Pac-Men that kind of float around and chew up or further compromise some of the cartilage and other joint structures. And that's really what is going on, is there's kind of this chemical warfare within the joint, within the tendon, within another musculoskeletal region, and that can lead to further perpetuation or progression of the problem. And so now we start to think about, well, wait a minute, this isn't just a mechanical issue, this isn't just a structural issue, meaning I had an injury in the past and that's why my knee is hurting, or I had part of my meniscus removed and that's why my knee is hurting. There's really much more to the story. There are many different chemicals involved, many different cells, a much more complex problem. So that then leads us to the need to consider all of this when designing a treatment program, when thinking about what can we do to intervene with some of this chemical process to mute some of these inflammatory chemicals, some of these unhealthy enzymes, to hopefully enhance the health of the joint and just improve the patient's symptoms. This is an example of a similar phenomenon within a tendon. So this represents a tendon, which is the connecting point between muscle and bone. And in the picture on the left, we have a healthy tendon with nicely organized collagen. And on the right, we have an unhealthy tendon, what would be called tendinopathy or tendinosis. And this can be a painful condition where that collagen that's normally nicely organized becomes disorganized. And you get an infiltration of unhealthy tissue, something called mucoid degeneration. And again, all of these fancy medical words, but the bottom line is that the environment of that tissue becomes an unhealthy one from both a structural standpoint and from a chemical standpoint. And we can see some evidence of this in the clinic. One of the things that I do regularly are musculoskeletal ultrasounds. And here's an example of that in this next slide. So these were two patients just this past week, actually. And on the left, what we see, I'm going to use my cursor to demonstrate. This is an ultrasound of the patellar tendon, which sits just below the kneecap. When folks have difficulty with this tendon, it's sometimes called jumper's knee or patellar tendonitis. This is a normal looking patellar tendon. It serves as a bridge connecting a bone up here to a bone down here. And it should look like this. It should be pretty uniform in its thickness and its diameter, and also in its color or ultrasound appearance. This is when it becomes unhealthy. You can see that it dilates in the center here, and it becomes darker. So when tendons are unhealthy on ultrasound, they become thicker and darker, and that's exactly what we're seeing here. This is a similar case, although a different patient, of a patellar tendon as well. Now we're looking at it in cross section, so we're sort of cutting through the tendon. And here's a normal, healthy patellar tendon. Pay attention to its thickness and its color. This is an unhealthy patellar tendon. It's much thicker, and especially over on this side, it's much darker. So that is the consequence of some swelling within the tendon. That's a consequence of some disorganized collagen arrangement and some inflammation and just generally, again, an unhealthy environment. So what can we do about these problems? This problem of degeneration, of a change in the landscape of the joint or the tendon or other structures that may be causing the pain? Well, one of the things that's important to me is to really consider all that we can potentially influence in terms of things that could improve the condition. And as I've given similar presentations, I've kind of changed them in order to be more holistic in nature, because really that's the way that I practice. I've made a point when I set up my private clinic to spend a lot of time with people. So we usually spend 45 minutes to an hour with every patient in order to be able to discuss all of these things, because in my mind, no matter how great a provider you are, if you limit that encounter to 10-15 minutes, you can only be so good within the constraints of that time frame. So some of the things that we walk through are, okay, what factors contribute to these degenerative processes of the body over time? Some of these are modifiable, meaning we can change them. Some of them aren't. Some examples of non-modifiable risk factors are age. We're all aging. Sex, in that sometimes males or females experience arthritis and tendon problems in different areas more than their counterpart. Genetics, we know that genetics does play a role. If mom and dad had a lot of arthritis, we might be a little bit more inclined to experience that as well. Trauma, if you have a history of being involved in a car accident, nothing you could likely do about that, and that could lead to joint troubles or other problems. But there's a whole lot that we can modify, and this is what I like to focus on in my clinic. And it goes well beyond just procedures. So even though I do a lot of procedures, and specifically minimally invasive procedures in my clinic, I really like to discuss this to be thorough and to be effective, because when you address the problem from all of these different angles, you can in fact be more effective. So some of the things that are modifiable are what we put in our mouths in the form of diet, the foods that we eat, and the things that we drink. Exercise, how much do we exercise and how do we exercise? Posture and alignment. So some people are born with certain alignments, meaning their bones are shaped a certain way, and that can influence the changes that occur over time. But as we all know, these days, most of us are sitting more. We're at computers, and for most of human history, I'll tell my patients that we would often, we would sit to take a break from standing or walking. But within recent human history, we now kind of do the opposite. We stand to take a break from sitting all day. And that has consequences. Our bodies aren't really designed for that. And so the way in which we posture, whether we have slumped shoulders or if we kind of lean over, that can have consequences, because over time, that will have a cumulative effect on our joints, on our tendons, and the rest of our musculoskeletal system. And then other lifestyle factors that we'll talk about. So let's dig a bit deeper. Again, why are we talking about this? Because what we're trying to focus on is restorative medicine. What can we do to restore a more normal joint environment, a more normal tendon? And these are some things we ought to look at. Diet. Now, this has been studied. They've looked at how different diets, different foods can influence the amount of discomfort we feel, the overall health of joints, the amount of inflammation. And as an example, they've looked at the Mediterranean diet, specifically in rheumatoid arthritis, but it applies more generally to arthritis, in that certain diets or certain foods, I more so like to focus on certain foods rather than specific diets. Certain foods contain chemicals, enzymes, nutrients that can benefit our joints. And I'll tell you, I experienced this personally. I think a lot of things you can't really empathize with or fully understand until you've had personal experience. And I did a little fitness competition some 6 years ago now, and in preparation for that, I was eating a very strict diet. It was a lot of vegetables, a lot of great sources of protein, a lot of healthy fats. And I have several injuries. I have a herniated disc in my low back, and a labrum problem in my shoulder, and a tendon problem in my wrist, and all kinds of previous weightlifting and sporting injuries. And when I was eating this diet, I felt like Superman. I had no pain. I felt great. And then the week after the competition was over, I went back to kind of eating whatever I wanted, and I'll tell you, I felt crippled. And it was within a week's time frame, and that was the only thing that changed. My wrist hurt so bad I could barely open a doorknob. My back was killing me. I was hunched over. It was amazing, and literally the only change was what I ate. So that was kind of the exclamation point at the end of the sentence that said, okay, this diet stuff is real. And those patients of mine that I can get to really buy into this, and who commit to this, notice an immense difference after changing their diet, often that are high in sugar and processed foods and that sort of thing. And I think that we're missing the boat a little bit if we just focus on or maybe a lot bit, if we just focus on procedures and other things that we can treat people with, that without having the discussion of diet and other things that are equally, if not more important. So I listed a couple things here, but we know that remaining well hydrated, for example, perhaps consumption of omega-3 fatty acids in the form of fish and other foods, these healthy fatty acids can benefit us. And I'll expand on that a little bit. I presented a lecture to my colleagues down at a local hospital on omega-3 fatty acids. And the bottom line is that these are healthy fats that are in fact found in fish and other sources, and they make up the membrane of our cells, of all of our cells. And when our body either needs to, it essentially pulls these fatty acids out of the cell membrane and uses them to either create inflammation or fight inflammation. And so if we're relatively deficient in certain fatty acids, like the omega-3 fatty acids, we might not be able to counter inflammation as well. And in fact, a lot of literature reveals the idea that we consume many fewer omega-3 fatty acids today than perhaps our ancestors when we were hunting and gathering and eating a much more natural diet as opposed to consuming all the processed food. So in fact, I found that when my patients begin to eat more fish or supplement with omega-3 fatty acids, it can often improve some of their joint pain. So in my previous lecture to my colleagues, I talked about the fact that many of us are relatively deficient in omega-3 fatty acids, which again fight inflammation. But yet, when people present with pain or with inflammation, we tend to recommend things like anti-inflammatory medications in the form of Advil or meloxicam, etc. None of us have a deficiency in Advil or meloxicam, but many of us are deficient, relatively speaking, in some of these other natural molecules. So doesn't it make sense to focus on these and to think about, well, maybe we should consider a higher intake of fish or perhaps nutritional supplements in order to offset this, to encourage this anti-inflammatory environment. So it's something to think about. Other dietary considerations: antioxidants, phytonutrients, which are nutrients found in vegetables and plant products, amino acids. There are many different molecules, nutrients within our food that can help to decrease some of these inflammatory molecules that I mentioned that are floating around in joints and around tendons, and help us feel better. Okay, is there a role for nutritional supplementation? Now, I always feel the obligation to put a disclosure at the bottom because I actually started a nutritional supplement company, and I've tried to formulate some products that would benefit joint symptoms and joint conditions. And I've had an interest in this ever since being a teenager and working at nutrition stores. And in fact, there is a lot of data, there's a lot of literature out there on natural molecules and nutritional supplements that can in fact benefit joints. And something I always talk about with patients is that symptoms are one thing, but structure and structure of the joint is another. So what we tend to focus on mostly is the symptoms, because that's what's most perceived by us. That's what we feel on a day-to-day basis. But I also like to consider dietary and perhaps nutritional supplement considerations for the sake of preventative considerations. And what can we do to perhaps enhance the health of the joint and perhaps prevent or slow down the progression of degenerative conditions? And I think now there's some good data to suggest that perhaps some dietary factors or nutritional supplement factors can in fact help us in that area. So there are things like boswellia, we mentioned the omega-3 fatty acids, curcumin, which is an active molecule in the spice turmeric, that very yellow spice that's often used in Indian cooking. Glucosamine and chondroitin, a lot of people have heard of. And then there are micronutrients like boron. And for example, there was a study that showed that people who get more boron in their diet, which is found in some areas more so in the soil than in other areas, they tend to have less arthritis. So some of this data we have to kind of approach with caution, but it's interesting and we ought not to ignore it. So these are some things that I think are worth taking a look at. Now we're moving on to exercise. So does exercise play a role? I think most would admit that, yeah, I've heard that exercise is beneficial, but the question becomes,
what the question I get from a lot of patients is, am I going to make things worse by exercising? And you have to take that on a case-by-case basis. But generally speaking, exercise has been shown to improve symptoms and perhaps even prevent progression of degenerative processes. Like, for example, if we have a tendon that has some degeneration within it, studies have found that when we exercise that tendon in a very specific way, we actually strengthen the tendon. We encourage some healing of the tendon. We prevent further degeneration of the tendon. So it's become very clear that exercise is critically important. It can, of course, also promote weight loss, which will be beneficial for our joints. It can strengthen the regions around the joint. So again, I'm picturing those of us who sit for most of the day and are not strengthening the areas around a joint. That joint is then more vulnerable. And similarly, they've also found that those who sit more perhaps have weaker cartilage, because it's sort of like, if you don't use it, you lose it. That old saying. It's true of our joints as well. So if you don't exercise, if you don't actually load, for example, a knee and the cartilage within that knee, it might become soft because it's not getting the proper mechanical stimulation from exercise. And then it's also been shown that exercise can help to influence that chemical environment of the joint. In other words, what molecules are within that joint that are either promoting health or leading to further degeneration. The next slide. This is just an example of a study that did look at this concept of whether exercise has a beneficial effect. And they looked at knee cartilage and in fact found that exercise can in fact protect knee cartilage for the reason that I mentioned, that it's preventing it from becoming softer, almost from a disuse type of scenario. I thought this was really cool. I'm in the process of writing an article about the cause of osteoarthritis. And I mentioned at the beginning that we're often taught that it's just wear and tear. Basically, I've worn the joint out, when really the story is, there's much more to the story. And there's a Dr. Daniel Lieberman, who is a professor of evolutionary biology at Harvard, I believe. He's written some really neat books, and he studies diseases for which we don't seem to be able to well adapted to. What I mean by that is diseases that are quite prominent and we don't seem to have a great solution to sometimes. For example, low back pain, cardiovascular disease, some of those things that plague many of us. And he began to ask why. And he actually looked at the problem of arthritis. And in the process of examining human remains, skeletons from, I think it was over a course of 6,000 years, he actually found that osteoarthritis is much more prevalent today than even prior to World War II, not that long ago. And so it raised the question, what in the world is going on here? Because if you think about it, we seem to move less today than we used to. We used to have to walk long distances when we were hunters and gatherers. We used to have to lift heavy objects routinely. Now we can do much from a chair in our own home, especially during these times, during the COVID quarantine. But the thought was, okay, if excess strain or excess activity leads to excess wear and tear on a joint and therefore arthritis, we would expect to see more arthritis in our ancestors, but he found the opposite. And so this kind of leads to that whole, well, wait a minute, maybe this exercise is essential to maintain healthy, robust joints. And he eliminated factors like us being, like folks being more overweight these days, and then us just living longer and thus being more likely to get arthritis. He managed to eliminate those factors from this equation and found that in fact it seems like activity, or the current lack of, is a big factor why arthritis is so prevalent. He also suggested that perhaps there were some other contributors, like the way in which we eat today. I don't often put long quotes in my presentations, but I think it's worth reading through some of these things. This is kind of neat. This is a quote from Daniel Lieberman. Knee osteoarthritis is not necessarily a consequence of old age. We should think of this partly as a preventable disease. Wouldn't it be great if people could live to be 60, 70, or 80 and never get knee arthritis in the first place? Right now, our society is barely focusing on prevention in any way, shape, or form, so we need to redirect more interest toward preventing this and other so-called diseases of aging. So a pretty interesting and provocative quote there. And it's not only about, my focus is not only on prevention, but again, what are these other treatments that we can engage in that can help to offset or even slow down the progression of the problem, and hopefully decrease your symptoms in the process. This is an excerpt from one of his papers that I thought was worth reading. It says, although altered loads generated by walking more frequently on hard pavements or with certain forms of footwear might be factors, that's kind of interesting to consider. Another possibility that merits more study is physical inactivity, which has become epidemic during the post-industrial era. Less physically active individuals who load their joints less develop thinner cartilage with lower proteoglycan content, which is just kind of this buoyant substance within cartilage, as well as weaker muscles responsible for protecting the joints by stabilizing them and limiting joint reaction forces. Chronic low-grade inflammation, which is exacerbated by physical inactivity, modern diets rich in highly refined carbohydrates, and excessive adiposity or body weight, can further magnify and accelerate loading-induced damage to joint tissues and may also directly affect knee osteoarthritis development. Evaluating which of these or additional features of modern environments are responsible for today's high knee arthritis levels is necessary. So he's also kind of getting at this fact that we need to open our minds to what else might be contributing to the problem in the first place, but then allowing it to progress, and ought we focus on these in the treatment process and not just talk about procedures that can be done. So what are other considerations? Daniel Lieberman mentioned them in the previous excerpt on the previous page, talking about things like we walk on hard surfaces now all the time instead of the softer ground of our ancestors. We wear different shoe wear. We wear shoe wear, some of our ancestors do not. But other considerations, trauma, again, previous injuries can lead to progression of arthritis, so that's part of the equation. Smoking, this is a big one, a big discussion I have with a lot of my patients, especially a lot of my veterans who came from a time when smoking was just thought of differently. And they're often surprised to learn that smoking really compromises the, for example, blood flow to their rotator cuff or the nutrients that are able to get to their joints, and it certainly slows down healing. The same can be said for diabetes. High sugar floating around in the blood can be quite damaging on those same blood vessels and can also impair wound healing and overall health of our joints and other musculoskeletal systems. Excess body fat, of course, we don't want to overload the joints. So a lot of things to consider here. And again, this is very important for me to be part of the discussion. Okay, let's talk about what your diet looks like. Let's talk about your activity levels. How can we optimize those to best improve your symptoms and your function? Then we do ultimately get into procedures, because by the time that a lot of people seek professional medical help, they're wondering about specific procedures. And some of them that we might perform in my office or that are available these days are things like hyaluronic acid or gel injections. Some patients have come to know those as, so they'll call them different names, rooster fat injections or rooster comb injections. Those products were first, the reason they're called that is those products were first developed from the rooster comb, that part on the back of a rooster, and that, like the game of telephone, that leads to chicken fat and other names that patients have heard circulating around. But these are injections of, in fact, hyaluronic acid, which is a normal, it's a natural compound found already in our joints that tends to decrease in concentration over time. So we can replace that, and that can help some patients. We'll talk more about that. Prolotherapy, which is injection of an irritant. Sometimes it can literally be sugar water or dextrose. And the intention here is to stimulate the body to begin to heal itself. And I'll sometimes use this for tendon problems, for example, or joints. And sometimes what the body has is a bit of a fix it and forget it mechanism. So if you injure a tendon, for example, you might try to fix it in the acute phases, but then after a while, it doesn't do such a good job at finishing the job. And so what you're left with is what you might picture as a bit of a frayed rope. And so sometimes you need to do different things, or you can do different things to stimulate the healing process again, to pick up where it left off. And prolotherapy is a tool to do that. Tendon fenestration, this is very similar in its intent, in that you can use a needle or other device to stimulate a tendon in order to reinitiate the healing process. Percutaneous tenotomy, gosh, all these long words, but that one just means that we're cleaning tendons up. So what they used to have to do in an operating room can now be done in a simple clinic room, like those at our office, where we use ultrasound, and we'll show this in a future slide. We use ultrasound to use a little device to clean some of the unhealthy tissue or junky material out of tendons, because as they degenerate, they get within them sort of a gummy or gelatinous type of substance called mucoid degeneration, which can be painful. So now, fortunately, through a minimally invasive procedure, you can remove some of this unhealthy tissue and initiate the healing process. Platelet-rich plasma, or PRP, is another one. This is known as an autologous procedure, meaning from self. So for this, what we do is we take a patient's blood from their arm, just like as if you were having lab work done, and we spin it in order to separate the components that we want. And in this case, it would be the platelets and other proteins within the blood. And the reason we do that in order to make this platelet-rich plasma is because platelets release a number of healing chemicals, and we'll look at that in a future slide. Something else that's often talked about these days is stem cell therapy, and it's an interesting one. There's a lot of misinformation out there about this, but essentially the idea is that we're using certain stem cells called mesenchymal stem cells in order to also encourage healing. And again, we'll look at that more in an upcoming slide. This is looping back around to that hyaluronic acid or those gel injections. Again, the idea here is that over time we lose this lubricating molecule, this lubricating shock-absorbing substance, and so we can inject it into a knee or other area in order to increase some of that lubrication. You can think of it as like Teflon on a pan, and it can help. But that's not the only way in which it does help, is by decreasing friction, adding lubrication. It's also been shown, this particular hyaluronic acid molecule, to bind to different receptors. For example, there's something called CD44. When it binds to this, it can decrease inflammation within the joint. So it has mechanical properties, it also has chemical properties, and I think it's important to remember that. So this is something we'll do routinely in my office for the right patient. It can be very helpful. Prolotherapy is what I was describing before, as this dextrose or sugar water, and it really is just a chemical irritant trying to reinitiate the healing process. In this case, we're demonstrating injecting into a patellar tendon. I showed some pictures of patellar tendons earlier. And it causes your body's healing cells to migrate to the area and again to begin to try to heal that tendon better than it was before. Tendon fenestration, I described how this is use of a needle or other device into a tendon. This area of tissue is the tendon attaching to the bone, which is this white mountain peak. And this needle is fenestrating the tendon, almost kind of making minced meat of it. I hope that's not such an unfavorable image there, but that's really kind of what we're doing in order to stimulate some healing of that tendon. It's pretty remarkable. Once you induce some degree of injury, a low grade injury, your body has a remarkable ability to then heal. So that's our intention here. Percutaneous tenotomy. This is what I was describing, where under ultrasound guidance, I hope you can maybe appreciate that we have an ultrasound probe here that's visualizing this little device being introduced into the tendon through a little, very tiny incision and into the most abnormal portion of the tendon in order to clean some of that unhealthy tissue out of the tendon. It's, again, a simple in-office procedure with very little downtime. And this is an example of where advancing technology allows for much more simple and potentially effective treatments for us these days. Okay, platelet-rich plasma, again, what we're doing here is taking a patient's blood, this is a picture of the patient's blood, and separating it, like we have here, And I think I have a future slide that'll show the way in which it separates, but basically we're trying to get rid of the red blood cells in most cases because those can often be inflammatory if injected into a joint or other areas. We're trying to isolate the platelets which are floating around in this plasma here, the more yellow plasma. And there are different ways to prepare this. So I use several different machines in my office depending on what the problem is that we're dealing with. But this is a very effective treatment for the right case. And oftentimes we will do an ultrasound evaluation to determine the extent of a problem and then decide if platelet-rich plasma is in fact a reasonable treatment option. It's used very commonly for problems like tennis elbow, which is a tendon problem on the outside of the elbow, or golfer's elbow on the other side of that joint, or rotator cuff problems, or Achilles tendon problems, or mild to moderate knee arthritis. Things like that tend to benefit from platelet-rich plasma. A lot of people say, well, what the heck are platelets? Platelets, again, are these little cellular fragments floating around in our blood. Here's a larger graphic representing a platelet accompanied by red blood cells in the background. And here's a slide where we actually took a patient's blood and looked at it under a microscope. You can see the larger pink red blood cells and then these tiny purple dots. Those are the platelets. So they're floating around in our blood, and in cases where we experience a cut or a laceration, they help that blood to clot, but then they also can be used to encourage healing, like we're trying to do in this case. This is the slide that I was referring to where it shows that when you spin blood, you can separate different constituents of that blood based on their density. So again, when you spin, the platelets will be found in a certain layer of that blood because, for example, they're less dense than red blood cells but more dense than other parts of blood. So you can effectively isolate them from a patient's blood. And then when you inject them, this is a busy slide, but what we're looking at here is platelets right here are derived from this bigger cell. And they contain all these little packets, these granules, these packets of growth factors and healing chemicals and anti-inflammatory molecules. And so when you inject them into a knee or around a tendon, they degranulate, they release all of these growth factors and healing chemicals. And that can really help to accelerate healing, to supplement healing, to optimize healing, and hopefully improve symptoms and function as a result. Similarly, here's another busy slide looking at a joint. And again, the purpose of showing these busy slides, it was partly intentional to harken back to the idea that arthritis and other degenerative processes are very complex. It's not just wear and tear. There are a whole bunch of receptors and molecules and chemical things going on within that joint or other area that are leading to the problem. And PRP can help some of those by inhibiting some of those molecules, those enzymes that can cause further problem, decreasing some of the inflammation, etc. So it works through many different mechanisms in many different ways. There's not a singular way, just one singular way in which platelet-rich plasma and some of these other treatments work. It affects many different things. There are many ongoing studies related to platelet-rich plasma. It's becoming more accessible these days. And it's something that we do, it's one of our most popular treatments and something that patients tend to do quite well with. This is another interesting topic. It's a topic known as allografts. I mentioned that platelet-rich plasma is an autologous procedure, meaning from self. Allo means other. So allografts are products that can be derived from tissue, for example, from perinatal tissue, from for example, placental tissue, placental membrane, or perhaps the umbilical cord, because they're finding that a lot of these tissues contain many different growth factors and healing chemicals and things like platelet-rich plasma that can also enhance joint health. So this is a very evolving area, and it's something that more and more studies are coming out every day about, and it's something that quite frankly is a bit confusing because it is such an evolving region. But the way in which some of these products are becoming available has actually changed because the regulations behind some of these products have similarly changed. So the FDA, for example, said that initially there was a question of should these be regulated as tissue products or biologic products, or more so like drugs, and they're kind of moving towards the latter. So a lot of these companies that manufacture products like this are applying for things called INDs, Investigational New Drug Licenses. So there's a lot of excitement in this area because we're going to see more and more products, different growth factors and healing chemicals, and utilizing tissues to help heal other tissues. And some of this stems from the world in which, the world of wound healing, where you would have, for example, a non-healing ulcer, and you can put different tissues on top of that, different sheets of tissues or even powders, and that finally allows for healing of that ulcer or that wound. So much of it started in that world, and we're going to see more and more of it. This is just an example of some previous studies that were done on some of these allograft procedures, looking at them, looking at those products and how they influence the course of a particular process like arthritis and how they could potentially improve symptoms. So we need more data in this realm, but we're certainly going to hear more about it in the future. Something else that's being done more and more in the operative setting during a procedure, and then even in the clinic setting, is autologous stem cell therapy. So again, auto meaning from self. So you can obtain stem cells from many different regions in the patient themselves. And this picture is demonstrating the case in which we would be obtaining some of that bone marrow and therefore stem cells from a patient's hip bone, and we can spin it very similar to how we do with PRP, and then isolate it, which is what I'm doing in this picture. I'm filtering that bone marrow before it spins, and then we can isolate those cells and administer to an injured or painful area. So what are we doing here? I mentioned before there's a lot of confusion about stem cell therapy, and I think when a lot of people think of stem cells, they think of embryologic stem cells, which are the type that George Bush Sr. talked a lot about, and that ultimately are fated to become a baby. They can turn into any tissue type. So there was a lot of controversy around that topic, but this is a totally different cell type. In fact, these mesenchymal stem cells, as they're called, and shown in this slide here, are found in all of our bodies. They're adult stem cells, and they're actually involved in the healing process whenever we injure ourselves. So this is kind of a cool picture because it shows that these cells are wrapping around blood vessels. That's where they live. They're also called pericytes, which means around. They wrap around blood vessels, and when a certain area experiences trauma or injury, these mesenchymal stem cells in the area can help to coordinate the healing process. They release a number of signals that tell other cells what to do and how to heal, and so it's a very cool process. And since these cells wrap around blood vessels, that's one of the reasons why we tend to harvest them from bone marrow, because bone marrow is very rich in blood vessels, and so you can obtain a decent number of these cells. And another important thing to mention is that the cellular component, or the mesenchymal stem cells, are very important in the healing process, but so are a lot of the other proteins and molecules and things found in the bone marrow itself or in other treatments that might be utilized in this realm. Something else that might be interesting to consider is that there's been this question about, when we hear about stem cells, we think about this cell turning into all these different other cells, and they have the ability to do that. But what a lot of the science has shown is that they don't seem to do that so much when used for a treatment, as in a bone marrow treatment that then is injected into a knee. What seems to occur instead is that these mesenchymal stem cells release all of these different signals that allow for healing and reduction of inflammation and improvement of overall health. So they're kind of, you can think of them as the conductor of the orchestra. They're conducting the healing process, and therefore likely reducing symptoms and improving function. We'll move on to this section. This is kind of an elaboration of what I was mentioning, in that the guy who named mesenchymal stem cells, Arnie Kaplan out of Case Western, actually suggested that the name be changed to medicinal signaling cells, because that kind of hints at the fact that they work primarily by releasing these medicinal chemicals rather than changing into all kinds of other different cells. And we're seeing more and more research in this realm, and we will continue to over the next several years. So this is one of my final slides, and I mentioned that we have work to do. We need more data on a lot of these treatments, and unfortunately, a lot of these things are very difficult to study. So in science, a lot of times we tend to be reductionists, and what I mean by that is we focus on one particular molecule, one particular mechanism, but a lot of things, a lot of treatments, a lot of interventions just don't work that way. For example, nutrition. It's very hard to study because what we eat, that food contains hundreds, if not thousands, of different molecules. Same thing with treatments like PRP. There are many different molecules. People are very different. The blood that we use for that treatment is coming from the patient themselves. So there's a lot of variability. There are many different mechanisms, a lot to consider. So it makes it very hard to study, but we continue to do so nonetheless because it's important to accumulate this data. I think that about wraps it up for today as kind of a general overview of restorative medicine. This is my private practice, Inertia Medical, where we mostly do musculoskeletal, or I should change this to restorative medicine, the word that I prefer.
Thank you, Dr. Gurman. This was recorded October 9th, 2020 at Ohio Living, Mount Pleasant for the Miami University's Institute for Learning in Retirement.